All right. Well, I promised that we would start as promptly as we could, so I'm excited to welcome you to the DIA's first ever virtual community forum. My name is Ryan Romaneski, and I am the current chair of the Dimond Improvement Association. For those of you who don't know, the DIA is a community-based 501c3 nonprofit organization with membership and participation open to all, regardless of where you live. We bring together residents, businesses, and other groups to engage in community projects, address issues of common concern, and to cultivate a friendly, inclusive Dimond district that is welcome to all. If you would love to learn more about the Dimond or about the Dimond Improvement Association, you can do so at dimondnews.org. Tonight, I am thrilled to be joined on our first community forum here by Dr. Rishi Desai, Chief Medical Officer for Osmosis, which is a comprehensive online platform that helps people around the world understand health more thoroughly. Dr. Desai is a national expert in public health and COVID-19 and a proud resident of the Dimond District. I also want to just acknowledge that many of you are opting to miss or record the Democratic National Convention right now to be here with us. So thank you for making the time to join us. And I hope that you're all recording Kamala. I will let Dr. Desai share a little bit more about himself, but before we do that, I'd love to just share some logistics for you all about Zoom and this Zoom forum. Would encourage you to familiarize yourself with your Zoom screen. There are a couple of features that we'll be using tonight. First is the Q&A feature. You are welcome to add questions as they come to you, and we will do our best to get to as many of your questions tonight as possible. And thank you to everybody who submitted questions in advance. You made my job a lot easier. We'll also be utilizing the polling feature tonight a couple of times. So if you're able to join by video, so you have access to that polling feature, we'll get a chance to get kind of the pulse of folks who are on this call, and you'll have a chance to weigh in. We won't be using the chat tonight to take questions. So if you do have questions, please be sure you enter them via the Q&A. And with that, I will welcome Dr. Rishi Desai.
Thank you very much, Ryan. That was a really nice intro. I'll say that I'd like to acknowledge the fact that Ryan is wearing a very colorful and exciting Wednesday Best shirt. Some of you might have questions about that. So although this is entitled to Ask Me Anything, if you have questions about attire, Ryan is the person to go to. I do recognize that there are about 11 folks on the call in addition to 3 of us. And so it's a pretty intimate setting. Please interrupt. You know, the goal is not for me to kind of launch into a speech. And so I'm going to have some slides. I want to go through some things that I think are not the intuitive things that we always hear in the news, but are still true and worth talking about. But the goal is to kind of get people asking questions. So Ryan, if any questions come in about any slide I'm on, please just let me know. And I'll go quiet and try to answer the question as it comes up. So I just thought we could launch in to briefly just who I am. In my background, I went through a very traditional pathway. I actually trained at UC San Francisco for medical school. I did my residency in pediatrics, and then I trained in infectious diseases. That was my fellowship. And after that, I went to the CDC for a couple of years, and I was in the division of viral diseases, where they would send me and people like me off on outbreak investigations. So when there was a new virus that had to be kind of figured out, or if it was an outbreak that needed to be stopped, they would send folks out. And I got to go on some really neat viral outbreak investigations. So I can certainly answer questions around kind of the CDC's approach to things like that, because I was one of the folks that was doing it about 8-9 years ago now. After the CDC, I left and joined a group called Khan Academy. Some of you may be in the middle of homeschooling your kids, may be familiar with Khan Academy, and I was working there for about 4 or 5 years. and since then left to join Osmosis. And Osmosis is a health education company, and we basically focus on nursing education, medical school education, and whatnot. And with COVID, obviously it's in the crossroads of kind of health and education and public health as well. And so it's definitely fallen in our laps. And so it's something I've been kind of doing more and more media work around. And that last screenshot is just of me being interviewed on CNN about COVID-19. And they've asked about everything from death tolls to vaccines. And if you have any of those kinds of questions that may be kind of percolating, again, please drop them in the Q&A so we can address it. So that's a bit about me. And as Ryan said, I am a proud member of the Dimond community. And so when I was invited to participate in this, I was, of course, really ecstatic. It was a huge honor. So I'm really happy to be here. Next slide. So this is something I wanted to start with, and it's a bit of framing around how to think about cases, hospitalizations, and deaths. And since I made this slide, of course, it's not 160,000 deaths, it's much higher than that. And we're now well over 5 million cases as well in the US. So these numbers are going to continue to tick upwards. That's obviously true. But the way to think about it, and certainly the way I think about it, is that there are kind of two things. There's been a lot of discussion around, are these cases real, or is it an artifact of simply the fact that we're testing more? That's something that has been discussed a lot in the media. And I just want to give everyone on this call a chance to think about it sort of the way I'm thinking about it, which is if you look at the left two graphs, the leftmost graph is new tests, and the second to the left is new cases. And if in fact it was that new cases are rising simply because we're looking more, then the two would look similar. Like as one goes up, the other goes up. They'd correlate pretty well. And you can see that's not the case, that actually cases were going down for quite a while as testing was rising. And then you saw this huge spike, in kind of basically July. And the testing didn't really go up significantly more at that time, right? Like there's no correlation there. So that I think visually helps you feel secure in knowing that the cases, the increase in cases was real and that it wasn't simply because we were testing more. So that's one point I want to make. The other point I want to make is the confusion that often comes up when people say, well, there are more cases, but we're not seeing an increase in hospitalizations or deaths. And maybe that means that we don't have to worry about the cases. And this is something I want to kind of draw attention to around this term called lagging indicator, or you could say leading indicator. So a leading indicator means that the first thing you see, typically one of the first things you see, is that cases go up. And once a case is identified, as you would imagine, it takes a couple of weeks for that person to get sick enough to go to, let's say, the local hospital. Once they go to the local hospital, let's say they check into the ER, they get hospitalized, then the hospitalization count goes up. But it's been about 2 weeks since they've had the disease, right? Because the disease has to really manifest. And so there's a 2-week gap or delay between a case and when you start seeing hospitalizations rise. Then that person's hospitalized or getting treated and they start getting worse. They're intubated, they're getting sicker, and ultimately they may die. That death happens about 2 weeks or sometimes even longer after the hospitalization. So there's kind of a 2-week gap. So case, then 2 weeks later hospitalizations go up, and then 2 weeks later deaths go up. So this is how you should start thinking about these numbers. You see one number rise. If I see cases rise, I already can kind of predict when the hospitalizations are going to go up 2 weeks later. And I can kind of guess when the deaths are going to go up 2 weeks after that. And of the three, the most reliable one is deaths, right? So you rarely are going to miss a death from COVID-19. You will miss some, that's true, and there's lots of reasons for why you might miss them. But cases, you're missing cases left and right. And so deaths of the three is probably the most reliable indicator. It's also the lagging indicator. The leading indicator is cases. So just a couple of wrinkles or nuances I wanted to point out in terms of how to think about data. Next slide. So another common question that a lot of you may be thinking about is events. You've got, grandma coming over for a pool party. You've got a friend that wants to come over for a dinner party. How do you assess the risk? And so I put together kind of my framework. These are 6 questions I would ask and how you think about it from a low risk standpoint to a high risk standpoint. And then of course, there's this risk chart that Osmosis put together that you can look at as well. And this is based on some data that we sourced in terms of how they were kind of putting it together. And there are a lot of wrinkles here as well. So let's go through some of these wrinkles. How many people are there at this event? You know, is it more than 10 or less than 10? How crowded is it going to be? Are you socially distancing or expecting others will do the same? Is COVID-19 on the rise? And at the moment, I would say, let's just say that it's on the rise nationally, even though there are some pockets of states, usually at the moment, the Northeast. But really in this area, it's on the rise. How long will it be? Let me caveat that. You might say, well, actually, Rishi, I saw the California County data, Alameda County data, it looks like it's going down a bit. And that's true. But what I'll point out is that it's still quite high, and it's higher than it was a few months ago. And we're still underreporting because of testing issues I'll get into in a minute. How long will it be, this event? So let's say you're running into, I don't know, let's say a friend's apartment for a quick, 1 minute to grab something, you're going to be back out. That's quite different than going and spending an hour there for a dinner. So is it less than or more than 15 minutes, this interaction you're talking about? Is it inside or outside? Low risk, of course, being outside. And tied to that is it well ventilated? So if it's inside, anything that you can do to reduce the risk, you should do. So for example, open the windows. If you're in a Lyft or an Uber, roll down the windows. Anything you can do to get more ventilation, that plays to your favor. And then finally, are people going to be wearing masks? So these are all things that lower the risk. And of course, you can kind of think through that with regard to going to a swimming pool or going to, let's say, a store to buy something, just thinking through like all these risk factors. Next slide. And so this is like another way of kind of visually stratifying or laying out the risk categories. So there's the highest risk all the way to practically none. And it's fairly self-explanatory. The cool thing I like about this graph is that it actually shows you that if the uninfected person wears a mask alone, they're actually reducing the risk, which is great. If the carrier, the person that is kind of unknowledgeable about themselves having COVID-19, but maybe spreading it, if they wear it, that reduces it even more. And of course, if you have both people wearing it, that reduces it even further. So mask wearing is something that in February of this year was not in vogue. In fact, the CDC, for various reasons, actually came out and said, hey, people probably shouldn't be wearing masks. They have since, as you I'm sure know, have reversed that position pretty aggressively and now are encouraging really everyone to be wearing masks when they're outside. Next slide. So another thing we didn't know back in February is exactly what COVID-19 and the virus that causes COVID-19, because that's the disease, the virus is called SARS-CoV-2, exactly what SARS-CoV-2 does to the body. And if you had asked me in February, what does it do? I would have said, well, it affects the lungs. And the left side of this graph shows that, or this picture shows that. And specifically the epithelial cells. These are the cells that are literally like lining your mouth. If you take your finger and just kind of touch inside your mouth, those are epithelial cells that you're touching. So those are literally the cells that are getting infected with SARS-CoV-2. And those are the same cells that line your nose, they're in your mouth, they line your eyes. All of those cells are epithelial cells. So it goes in, it kind of hits the upper airways, the back of the throat, the nose, what they call the pharynx, kind of where you're swallowing food or water. And that's that picture on the left. And then it goes deep into the lungs. And one point I want to make is that in young kids, so kids under 10, for some unknown reason, I have a couple of ideas I can share with you that have actually been borne out in the science, but for some reason, they just don't seem to be spreading it as much. And let me say that again, kids under 10. So not kids between, let's say, 10 and 18. And oftentimes studies will just say kids and kind of lump 0 to 18 altogether. But I really mean young kids, 0 to 10. They're not spreading it as much. And some thoughts on why are that perhaps they have other viruses in their nose. And so there's this idea of viral interference where SARS-CoV-2 just can't get in there as well because there are other viruses hanging out in kids' noses. So that's one option. Another option is that maybe they just don't have as many of the receptors in the epithelial cells that this virus really enjoys binding to. So maybe that's the reason why young kids aren't showing the same levels of virus as older kids or adults. Now, on the right side of the screen, you've got endothelial cells. These are the cells that are inside the blood vessels. These, we didn't really know that the virus affects these a few months ago. We know this now. And what happens when the virus affects these blood vessels is it sets you up for heart disease, strokes, these kinds of issues. That's why I put a heart in kind of what looks like the outline of some blood vessels in the brain. These are the vessels that get affected. And it's also helpful to think about it from the standpoint of chronic diseases. So if you have someone that has heart disease or diabetes, which of course affects the blood vessels, or has had a prior stroke, they're at high risk because we know that the virus targets these cells. And again, we didn't really fully appreciate this a few months ago. So next slide. So you've heard about a number of medications and treatments that are out there. Dexamethasone is one that's been in the news quite a bit. Also convalescent plasma and remdesivir as well as an antiviral drug. I put it on this axis just to kind of point out again, something that I think is often missed in typical reporting I've seen, is that dexamethasone is very cheap. It's very available. And so you can find dexamethasone in the US. You can also find it in most international low-income countries or settings. So it's a great, great tool that we can use to help mitigate a lot of the disease. And you'll notice the recommendation here, and if you look in the bottom right, this is an NIH recommendation. The recommendation is for patients that are on oxygen or are ventilated. So if you have, so initially when you need support, you get, kind of what they call nasal prongs in your nose, and they increase the oxygen that you're getting. So it's not just room air oxygen, which is 21%, but it's much more than that. So if a patient's kind of more subtly ill, dexamethasone is suggested. If they're very ill and they need intubation or other mechanical ventilation, dexamethasone is still recommended. Then you have convalescent plasma. This is essentially kind of the idea that, let's say person A is sick with COVID-19 and they recover, they have in their blood antibodies. And those antibodies, let's say Ryan recovers, Ryan's antibodies could be given to me if I'm actually actively sick. And that's something that is actually being studied. It's actually being used quite commonly now, I would say, in most hospitals in cases where people are sick. But there's no formal recommendation. It hasn't actually been fully studied. And it hasn't been borne out nearly to the level of remdesivir or dexamethasone. So it's still kind of not a formal recommendation, but it's used quite widely. And it's kind of in the middle. It's available. It's not as cheap. It's not as easy to use, et cetera. And then you've got the far right, which is expensive and fairly unavailable. So remdesivir, great studies have come out showing that it seems useful. But again, it's recommended for individuals on oxygen, but not ventilated. And what that means is that, if you're a little ill and you need some oxygen, if remdesivir can be given, it'll be given. But if you get pretty sick and you're ventilated, the recommendation is not, by the NIH actually, as of when this was put out, is not to give you remdesivir. And again, it's mostly because of the availability of it. So I just want to kind of point out that even when we have these great drugs, these practical logistics of cost and availability do affect who gets what treatment. Next. So vaccines, we talk about this all the time. I thought we'd walk through just briefly what happens in terms of vaccine development. How does it work normally? And typically vaccine development takes 10 to 15 years. On the low end, we had mumps vaccine where we had a lot of kind of research that was done beforehand, and that clocked in at about 4 years. So on the low end, vaccine development takes about 4 years. And think of that as almost the world record on vaccine development. And now COVID comes along and we say, hey, how fast can we get a vaccine? And we say, well, maybe 12 to 18 months. That is astonishingly fast, just to put that out there, that we've never done that before. So just to be able to say that is a pretty big feat. Now, the normal way it works is you do pre-licensure studies, you do them in animal models, and a lot of the vaccines, there are many out there that are being kind of put through this test, have been used in macaque monkeys, they've been used in mouse models, and they seem to be effective. So that's great, that's good that they seem effective. They now go to phase 1, where they're used in hundreds of people, and it's mostly to check safety. Not many, a few vaccines have made it through phase 1. A lot of studies right now that make it through phase 1 are skipping phase 2. And that's because the government is essentially saying, hey, rather than doing this extra step of dosing and things like that, let's skip that. We will guarantee that we'll come in, step in and pay for a successful phase 3 study. So if you walk out of phase 3 successful, we are not going to ask you to have to go through phase 2. So that's one of the reasons why this is happening so quickly. You might be thinking, how do we go from 4 years with mumps vaccine to 1.5 years? One step that was kind of removed for a lot of these vaccines is phase 2. Phase 3 is on the order of thousands of people. It's not necessarily 30,000, I have to fix that slide, but it's on the order of thousands of people. So you go from hundreds to thousands. And that's where you're testing for efficacy. Does this really work? And typically there, what you're doing is you're taking two groups of people. One group gets the vaccine that we believe at that point is safe. The other group does not. And then you wait and see which group gets more COVID-19 disease. And you would hope that the group that had the vaccine doesn't get the same level. Now, I want to point out to you that it's not to say that they're going to get no COVID-19 disease, but really you want to make sure they're not getting severe disease. They're not getting, hospitalized with COVID-19. Maybe they have some mild disease. That would be acceptable. And so that's essentially what you're trying to look at is, are you averting hospitalizations? Are you averting deaths? And that's the clear endpoint. And if you can show that, then we would all feel very confident that this does seem to work to avert the very thing that we're really worried about. There are some practical considerations. Are you going to actually watch that go to completion? Which is why I put, do they need to be completed for the EUA? EUA is emergency use authorization. Or are we just going to say, hey, let's do it in the first 5,000, watch them, and if we get any signal, we'll just kind of go with it. And that's the worry that I have. I worry that there may be a chance that the federal government will say, well, we haven't completed phase 3, but early studies show ... because you really want to see this go to completion, both for safety and efficacy reasons. Yeah.
Rishi, one question here about this slide. Are people who are participating in clinical trials, are they still asked to follow typical, prevention strategies, physical distancing, wear masks, or are they just essentially asked to go about their normal lives as if we were not in a pandemic?
It's a great question. And it's a hard question because even if they're asked to do something, you're not really going to necessarily know if they're doing it, right? Because you see all this messaging around how we should be doing something. So even if you're in a certain trial, you wouldn't necessarily get messaged differently or kind of change your behavior. Typically what happens, Ryan, is you want to see how it works in a normal setting. So you wouldn't tell them to necessarily change their behavior. You tell them, hey, do what you normally would do. If you normally would wear a mask, wear a mask. If you normally wouldn't, don't. I think that, and I don't have any visibility into the actual instructions that are being given for this vaccine trial, but typically you would ask people to continue doing what they're doing. Because what you want to see is what's the effectiveness in a real world setting. And right now we're in a pandemic setting where everyone is supposed to be masking up. So you'd presumably have them do the same thing. One challenge, since you asked that, one challenge with phase 3 trials is we're not seeing a lot of non-white participation in a lot of these trials. And so then one concern is, well, maybe it seems safe and effective in one group, but is it really then transferable? Is that knowledge transferable to, let's say, Black or Hispanic or Indigenous populations where we know that the rates of mortality and hospitalizations are way higher? So that's an issue. Next slide.
One more, if I could, one more
question
totally. About this slide. Related to the 30,000 or thousands of people in phase 3, are all those people essentially enrolled in and tested at the same time, or are they kind of phased in as people sign up? How long does it take essentially before you have enough people and they've been in long enough for you to have results that matter?
It takes a while. And that's the big challenge, is that it takes a long time. Typically it's rolling enrollment. So to answer your first question, just point blank, it's not all at once, it's rolling usually. And it takes a while because you have to get thousands of people enrolled in both arms. And then you just kind of have to wait. And if you're not seeing a lot of hospitalizations and deaths in either group, then you have to really wait a long time before you start seeing a difference, right? And keep in mind, typically, and each vaccine trial has got different inclusion and exclusion criteria, but typically you want to see for a new vaccine, does it work in your, let's say, healthiest population first? So usually people that are kind of enrolling in this are 18 to 65. And so as we know, the risk goes up with 65 plus, but that's not usually the group that's initially getting the vaccine. It's usually your healthier young adults or middle-aged individuals. And sometimes they even exclude people that have certain chronic conditions. So you're really getting a healthier cohort than where we're seeing the bulk of the disease and disability. So that's another concern, is that, hey, we've seen that it works safely in this population. How can I trust that kids can get the vaccine? How can I trust that my grandma who's 90 can get the vaccine? That type of person wasn't even in the trial. And so there is that sort of concern as well. Okay, cool. So another thing that I think a lot of people may not know, and it's obviously a bit of speculation here, but there's this term R naught that got thrown around a lot. I guess that rhymes, in the beginning of COVID-19. And R naught is this, it's a lot simpler than it might sound, but basically it's, hey, for every one person that gets sick with COVID-19, how many more people are going to get sick, right? If the answer is one more person, then you're kind of in this, this stalemate with the virus, right? Like it keeps getting one more person, and so it never really grows. If it gets to two, then it's like, oh my gosh, the virus is doubling. You know, we're losing this battle. And if it's under one, then we're winning, right? Because every one person, maybe only half a person gets sick. And obviously with that sort of an example, that's kind of silly. But let's say for every two people, one person will get sick, then you're kind of squashing the virus out. So that's R naught. And typically, based on what I've seen, the studies have generally said R naught for COVID-19 is between 2 and 2.5. Great, so put that number on the side for a second. Seems like a kind of interesting academic exercise. But then there's this other term called herd immunity. And talk about herd immunity, are we going to get to herd immunity, et cetera. Well, what is the definition of herd immunity? Well, it turns out there's a math definition. It's actually related to R naught. So herd immunity is just 1 minus 1 over R naught. They're very, very closely related. It's like finding out that you have a cousin you never knew you had. And so if you plug in R naught of 2 or 2.5, you actually calculate, and it's a pretty simple calculation, that's why I put it on the screen, herd immunity is 50%. If you think R naught is 2.5, then herd immunity is 60%. There's nothing kind of magical about these numbers. It's just math. And what I think people have to remember is that whenever we do get a vaccine, and I'm pretty confident we're going to get some vaccine that shows some effectiveness. But the question is, what does some mean? Is it 100% effective? I don't think so. Generally speaking, we're going to get a vaccine that's not going to be 100% effective. And in fact, none of the vaccines are at 100%. They all have kind of a failure rate. And as an example, a benchmark, a flu vaccine, which many people are familiar with, usually works around 50 to 60% of the time. So its VE, or vaccine effectiveness, is 50 or 60%, depends on the year. And so if we imagine that this is better than that, let's say it's 75%. And let's imagine that the uptake, the number of people willing to get vaccinated, is 66%. Well, then just do the math. 75% times 66% gets us to 50%. So we barely reach the threshold of herd immunity, barely. Now, what if it's not 66% uptake? Maybe large communities say, you know what, in my community, uptake is only 40% or 30%. Then this magic bullet of a vaccine starts looking really, really sad because it's not working. Because people are vaccinating themselves, but you're not seeing the effect you needed. And you're still seeing the virus win, even with a vaccine. And I want to just drive home that message. Even with a vaccine, if enough people don't take it and the effectiveness is not high enough, we may still see the virus spread. And this is going to happen in communities. So it may not be nationwide, but in some communities where vaccine uptake is not great, you're going to see it continue to spread. So I just want to flag that and make sure that people really flag that in their heads, that vaccine is not kind of the end all and be all, that we have other battles in front of us in terms of vaccine uptake. And then finally, just kind of an interesting point, which is that, oh, sorry, go back, sorry. Which is that there is some evidence that actually getting the vaccine might be more effective at long-term immunity than getting natural disease. And that might, I don't think people think about that. They're like, oh, if I get natural disease or I get the vaccine, they both kind of protect me. And that may not be true. It might be true that actually the vaccine does better than natural disease. And here's why. That natural disease, what we've noticed is that one thing that this nasty little bug does is it dampens your immune system. It specifically dampens one of the chemicals that allows you to remember it. And so if it's literally doing this, kind of playing this trick on you so you don't remember it very well, then the natural infection is not as effective as the vaccine, which doesn't have that component. So I just want to kind of plug that in as another reason to get the vaccine out there, even if you think you've had the disease or you've definitely had the disease. Next slide. So anyway, this is a hero of mine, so that's why I put him on the slide. Bill Foege is, if you look him up, if you're interested tonight, just go look up this guy. He is truly a legend for humanity. He was the former CDC director, senior medical advisor to the Gates Foundation. He led smallpox eradication. And just to say that again, he and obviously a team of many, many, many people, but he was in charge in many ways of helping to get rid of smallpox off the face of the planet. He knows a lot about eradication of disease. He is the co-chair of the National Academy of Medicine's committee on, and this is a mouthful, so this is the part that matters, equitable allocation of vaccine for novel coronavirus. So there is a committee, he is the co-chair of it, he is a stellar human being, and they are right now drafting out who and how vaccine should be distributed, like who gets it, how it gets there. So they're working on plans to lay this out. Obviously, you need to follow plans. So that's a whole other issue of the politics of like what happens when scientific plans get out there. But they are working on putting out kind of what the order should be. And it couldn't be done by a more amazing person, is all I'll say. So definitely a lot of optimism on that. Next slide. I think that should be all. Yeah. And you may be muted, Ryan.
I am, in fact. Thank you very much. Great information, great overview. Certainly raises a lot of questions for me, likely raises additional questions for our audience. We will would encourage folks to add your questions to the Q&A. We've got a group of questions to get us started here, but if you do submit your questions through the Q&A, we'll make sure that we do our best to get to them. Rishi, just to kick us off with some questions that came in advance. In your overview, you mentioned, I think on the slide around, mask wearing, you mentioned kind of this idea of symptomatic versus asymptomatic carriers. And it seems to me the list of symptoms associated with COVID-19 is constantly growing. With flu season coming up, I suspect there'll be a lot of people wondering if that tickle in their throat or that upset stomach is COVID-19. Could you talk a little bit about what maybe is the laundry list? What are the laundry list of symptoms? And then what are the symptoms that, if present, you would really encourage someone to take seriously or to get tested?
That's a really good question. And I'll start by empathizing, because I think these lists get a little bit overwhelming. And if you are like me or like most people I know, they almost become meaningless, right? Because you're like, oh, so any sort of headache, fever, cough, runny nose, sore throat, losing my sense of smell, any of that stuff could be COVID. And the answer is, yeah. I mean, we have now 5 million people that have gotten sick with COVID, and they each gave us our list. And believe it or not, now we've got lots and lots of complaints that we've seen that kind of go along with COVID. The most common ones are fever, and just to define fever, because that may be differently defined by different people, but generally 100.4 Fahrenheit or 38.0 Celsius or higher. Like that would be considered a fever. And
like at any point, or for a sustained period of time, or?
Really at any point. So at any point, if you kind of ever touch it and kind of go down, let's say you go down forevermore, I'd say that day, in that moment, you had a fever. Typically, people don't get to that point. And those fever curves are kind of based on population norms. So of course, you're going to find some people in a population that do hit it and actually technically never had a fever. But generally speaking, that's kind of the cutoff we use, is if you touched it, even whiffed it, then you can. So So that's a fever. And then the other symptoms are the ones that I care more about. So respiratory symptoms. So cough and shortness of breath are kind of the triad people usually go with. Cough usually lingers for a long time. The one that's really worrisome is shortness of breath. I mean, typically nobody should feel short of breath. And if you're feeling short of breath and that's not normal for you, in other words, you don't kind of always feel short of breath because you've got congestive heart failure or other reasons for that, then that's something to definitely take seriously. And so that's the one that I would say is of the three, the most concerning.
Mm-hmm.
And the most useful advice I can give, I think, is don't worry so much about the symptoms, worry more about the change in symptoms. So for example, if you have a 38.0 fever and now it's 39, that's a change in symptoms. If you're having a cough and now it's happening to the point where you're like having a hard time eating because you can't even like get through your meal without coughing, that's a change in symptoms. If you're so fatigued you can't get out of bed, that's a change. If your breathlessness, and try to measure it somehow, but I always recommend is do something simple like just read a paragraph out of a book and read the same paragraph the next day and just kind of check how you feel reading that standard paragraph, right? You know, there are kind of ways to measure this stuff. Then that would be a change. And then the key thing to think about from my perspective as a physician is if someone came in and, you know, let's say Thomas comes in and says, hey, I'm feeling awful. I think I might have COVID. And let's say we go through the checklist and we say, yeah, it seems like you might. And let's say he comes back positive. I've got to make a decision. You know, do we admit Thomas or do we leave him at home? And the things that make you want to admit someone, these are the things. Are they high risk for getting worse? So do they already have other conditions where, gosh, they've already got this pulmonary issue. Their pulmonary function is already 50% of normal. If they lost 10 more percent, that's terrible. That's very different than if you have 100% lungs and you lose 10%. You might not even notice it. And so really, what's their baseline kind of a normal state of health? And if they're already a tenuous type person, either because they're very old or because they have a lot of comorbid conditions or anything like that, then I'm going to want to admit that person. Another thing is, are they getting worse? And is that worsening impeding a key function? So a key function for Thomas and I, and Ryan, all of us, is to drink water. Like, are you able to take down fluids? Are you peeing a normal number of times a day? And if you say, gosh, you know, I only went twice today. Whoa, really? Why only twice? Were you unable to hold down fluids? Yeah, because I felt nauseous. Okay, maybe we need to admit you for IV fluids because you're not able to hold down fluids and you're actually dehydrated. So that's a concern. So that would be a reason to go to the hospital and get admitted. Another reason could be you're so breathless, you're tiring out. You literally can't keep breathing at this rate. You're going to fatigue. So we need to give you oxygen to help you out. So those are kind of the three big categories. I would say, do you need to come in because you're high risk? Are you having difficulty with fluids and fluid status? And is your breathing concerning where I'd want you admitted? Those are the three big reasons. If any of those things are happening at home, you got to get on a call and get checked out. And today with telemedicine kind of expanding services, it's easier than ever, I would say, to kind of get someone on a call. And you should not hesitate from home to just get free advice. That's what people are doing 24/7. I do telemedicine as well. It's very easy to get some quick advice.
Do you recommend just Googling WebMD and diagnosing yourself? No, I'm just kidding. That's what I do.
Okay.
Yeah.
We'll do a whole other AMA with Ryan.
Okay. Okay. That's great. That's great.
Like totally different advice. I'm like, okay.
Yeah, exactly. Exactly. Can you just, in the same vein, can you talk a little bit about do we know why some people are symptomatic and some people are not?
So the quick answer is we don't know. We have a lot of ideas. So let's talk about kids versus adults. So when kids get COVID, one thing you notice is that their cells don't send out tons and tons of chemicals, cytokines. You just don't see it. So their response is quite muted or calm. If you have the same infection in an elderly person, tons of chemicals going out. In fact, we call it cytokine storm. And it's called storm for a reason. It feels like a storm is going on in their blood. And so it's really, in a way, it's almost less the virus, but more their response to the virus. So we believe, this is one hypothesis, is that it's this cytokine storm response that you're seeing in older folks that is actually causing a lot of the disease. And if you could actually suppress it, maybe they wouldn't be so sick. And guess what dexamethasone does? Dexamethasone is a steroid. It suppresses a lot of those cytokines from being released. And generally speaking, people do better when they've had a little dexamethasone.
Mm.
And so that's actually one of the reasons why we believe dexamethasone works and why some people seem to get it more than others. And so that's a half answer to your question in the sense that there are some ideas out there.
Great, thank you. Another question that came in advance, but also kind of related to something that somebody just chatted is, there's been some news more recently about whether the virus is transmissible in air, kind of airborne transmission. Can you talk a little bit about what's the latest on how the virus spreads most often? I know in the beginning it was a lot of focus on washing hands, and then it was more about masks, but we don't think it's in the air, and now maybe there's some evidence that it's that the virus is airborne. Can you talk a little bit about our current understanding?
Yeah, totally. And so some of the terminology gets a little bit wacky, but I'll walk through it with you. There's the idea of droplets and the idea of airborne. And I think this is fundamentally confusing because I think that they were not named very well. But basically, everything that's in the air got there because it was on a droplet. So let's just start with that. And really, it's just about big droplets versus little droplets. The big droplets are the ones that gravity affects the most. And so they're going to descend quickly. And when I sneeze or cough or, any of those kinds of things, it's going to land kind of in almost like a little range, shower in my kind of 3 to 5, maybe 6 feet, right? Like this little range. But then there are the smaller droplets, and those droplets kind of linger. Almost if you imagine a soap bubble that you create, the tiny little bubbles that just kind of like linger, and you're like, how's that going up? I don't understand how it's going up. Is gravity not affecting it? And so it's sort of like just catching little winds here and there and just kind of bubbling up, and it kind of drifts down and it goes back up again. Those tiny little droplets, they're microscopic. I don't want to imply that they're the size of a soap bubble. They're microscopic, but they really linger in the air for hours. And they go much further than 6 feet, just to be totally clear. So what I want you to start thinking about is it's not about whether you got the virus or didn't get the virus. It's not like a light switch where it's like literally on or off. It's a dimmer switch. The amount matters. And if you get less virus, you may not get sick at all. And if you get a very little bit of virus, you might be completely asymptomatic. And so what you have to think about is if you're in the rain shower area, then you're going to get a lot of virus. And there's a good chance you're going to get sick. Maybe the same person standing 15 feet away versus 3 feet away is really the difference between asymptomatic and mild symptomatic or severe, right? It's the amount that matters. And so anyway, going back to whether it's in the air, it seems quite clear, I would say at this point, the WHO has come out about this already, that it is airborne, that it does linger in the air. There's lots of different types of data that kind of point to that. And so the fact that it's airborne is less of a debate in my mind. But really the question is like, how long does it linger? What's the real risk if you're 15 feet away versus 3 feet away? And each virus is slightly different. A good example is measles. Measles, a tiny amount of measles, even across the room, is good enough to get you sick. And that doesn't seem to be the case for SARS-CoV-2. But having said that, it seems much, much more effective at getting people sick than most of the viruses that we're talking about. So it does seem to have some airborne type quality. But again, I just want you to think about it in terms of small droplets and how it kind of carries out there. And really about viral titers and viral load and how much you need to get sick.
So I think that kind of, somebody asked if we could put this slide back up. And I think this connection between sort of mask wearing, a lot of questions have come in about mask wearing. I think you're sort of getting to that in what you're describing right now around why are masks effective at protecting you, and then also the relationship between mask wearing and physical distancing. Can you just sort of maybe cover that again for folks who maybe are still processing what you shared?
Yeah, absolutely. Let's start with masks from two different points of view. So let's say that I have COVID. Let's assume that. And I meet Ryan in the grocery store, and Ryan does not have COVID. So I'm the asymptomatic COVID-19 carrier, and Ryan is the uninfected person. So let's first take it from my standpoint, right? And our goal is, of course, to minimize the chance that I give it to Ryan. So if I'm wearing a mask, and actually, I have one right here, so I can even kind of show it. If I'm wearing a mask like this, right? Then if I sneeze, cough, any of those kinds of things, let's say I could count the amount of viruses. Let's say I could count the viral particles that I have in my nose and my upper airways. And let's say that number is 100. Well, the moment I cough or sneeze out, and if I'm not wearing a mask, that's 100 viruses in my environment. And we already said it's kind of related to distance. So maybe 80 of them make it to 3 feet, maybe 10 more make it to 5 feet, and maybe only a few stragglers kind of make it out there really far, right? So again, it's a dose issue. So that's great. If you're far away, you're golden. As you get closer, you're kind of getting into the concentrated range. The moment I wear a mask, 70 of them land on this, right? The large droplets, like this gets soaked. So now we're really talking about 30 left. Where did the 30 go? Well, maybe a few shot this way, a few shot up and down. You're not getting 100 out there, you're getting 30 out there, right? Mm-hmm. And they're not going in the same direction, right? Like for me to get you, Ryan, I've got to go horizontal, right? Like just think of like basic physics, right? Mm-hmm. I can't expect to get you by shooting up. Like you're not like hovering above me. And so the mask is really deflecting the vector that is getting you, right? Mm. It's protecting you. So even the 30 stragglers, how did they get out? They escaped in weird, wacky directions. They didn't actually effectively get to you. So that's the first thing. That's from my perspective. Mm-hmm. Now let's switch to your perspective. You don't have the virus. You're wearing a mask. Let's say that you are in kind of this environment. Turns out that some masks, and actually there's a bunch of studies on this now, depending on how they're made, are actually pretty darn effective. Now, you've heard the term, I'm guessing, N95, right? Mm-hmm. So what does 95 mean? 95 means 95% of these small viruses are not gonna make it past that filter. 95%, okay? So that's great, now we have that number. How effective is this thing? Well, depending on which mask you're wearing, they can be up to 95% effective, which is incredible. So you're saying this mask, if I wear it on my face and it's covering kind of most orifices, there's not too many entry points, it's almost as good as that N95 mask that nobody can get their hands on in the hospital. And that's true. And so we really have to be thoughtful from that perspective because it's filtering, right? So that number 30 or whatever I said, that kind of sneak out. Now let's say you're hit by all 30, which would be terrible luck, but you're hit by all 30. So it's like 95% of 30 is what you're left with, right? So you're down to almost nothing. So, and that's assuming you got hit by all of them. So it's a numbers game, right? And if you're hit by 60, 70, maybe you're in the hospital. Maybe you're hit by 95, you're gonna end up dead. You're hit by 10, you may not even know it. And so it's a numbers game, and these masks dramatically reduce the numbers.
Great. Could you talk a little bit about other forms of transmission? Do we know how people most often get infected? Do people frequently get infected through things like countertops, virus on clothing? I've heard different things about kind of the time that the virus lives on your counter or a piece of mail. What do we know about other means of transmission?
So all those surfaces that you're talking about, the fancy word for it is fomite, F-O-M-I-T-E, fomite. And it kind of lumps together all of the things that you just said, cardboard, metal, doorknobs, remote controls, et cetera. And now that I've introduced this idea of the numbers game, let me keep going with it just to show you what happens. So I sneeze and it lands on a pair of scissors that I'm holding here. So then I come back a day later, and instead of 100 virus particles, it's down to 10. You usually see logarithmic decay. So meaning like a 10th on the next day, a 10th the day after that. So it goes down to 10, then it goes down to 1, then it goes down to 0.1 if you could measure that. And so now I report in a paper, hey, guess what? It survives on scissors for up to 3 days. And you think to yourself, oh my gosh, I got to clean the scissors, right? I got to clean everything. But what you're missing in the story is that it rapidly decays in the environment. I mean, there are lots of terrible things about SARS-CoV-2. There are a few good things about SARS-CoV-2, which is it's enveloped, and enveloped viruses generally suck at being hardy in the environment. So that's great. That's great news for us, right? So it doesn't do great in the environment. And so in spite of the fact that we see these papers coming out talking about kind of surfaces and how long it lasts, the real concern is frequently touched surfaces. So I'm really concerned about I have not done this, but if I were to go on a bus and touch the handrail, right? Someone may have just sneezed on that handrail. Maybe there's not a day between me and that person. And now I'm picking up basically 80 virus particles, right? And then I go and do something crazy, like I lick my hand. I now got 80 on my tongue. I would never do that, obviously, but that's the sort of thing that you don't want to have happen. So let's say that there's now I'm going to make this realistic. My child is 3 years old. He goes to a daycare event, let's say, and they say, yeah, we took the bus. And, and he's 3, so he does things that probably I wouldn't recommend doing, like licking his hands. And then he comes home and has a fever 3 days later. Is it possible that he got from the bus? 100% possible, so there's absolutely, because I know what he does, I know how he is. And that's the kind of thing I would worry about. But generally speaking, for folks that are pretty diligent at hand hygiene and are thoughtful about these sort of situations, the risk is much lower with a fomite situation than it is with a person-to-person situation where you're having dinner with someone, they're around you, things like that. You may have frozen, Ryan, or you're very still. Okay.
Am I back?
Yeah, you're back for me.
Okay. I was just holding steady for a minute. The next question is actually about testing capacity. I think, at the rates of infection, it's increasingly likely right now that we may get exposed to someone with COVID-19, even if we're not licking our hands or licking the bus seats. What's the state of testing capacity right now in the Bay Area? And do we have enough tests? Why is testing taking so long? And can you talk about the different types of tests that are available?
Yeah, that's a lot. I'll try to get through it real quick. So let's
Sure.
start with the last one. That's probably the easiest. So the different tests are available. In general, we break them up into 2 categories, RT-PCR and serology. And RT-PCR is saying, hey, is there any evidence of the virus's RNA? Can we find it? And generally, if you can find the virus's RNA, you kind of presume the virus is there too. So if the virus's RNA is around, if it's in your nose or if it's in your mouth, there's a saliva test coming out now, then we think, oh, maybe you have the virus. And in present tense, you have it now. And the other test is serology. It's looking for antibodies, which is to say, if you have antibodies, they're typically there after you've cleared the virus. Sometimes you can have it concurrently, but usually it's after the virus. So it's really not, do you have it now, but did you have the virus at some point? So they're kind of separate questions, right? In terms of what it's trying to answer those 2 tests. In terms of the availability of testing, I was going to answer it one way, and then you added a clause that makes me think differently. You said, here in the East Bay, I think, and it's really regional. So I can tell you national data, but national doesn't tell you what's happening here in the East Bay versus, let's say, Miami or, New England. And even within the East Bay, I believe it's quite different between, let's say, a rich community in San Francisco and even, let's say, just down Fruitvale. The Fruitvale district where the station is, that is one of the hardest hit areas with COVID-19. And it really, really correlates well with poverty. And so lots of low income neighborhoods are going to get hit much harder with COVID-19. And those are the areas where testing is probably least available in general. Like, I don't want to make that as a blanket statement because I think some poor communities are actually doing pretty well. But in general, it's hard to get testing. And there are a couple of issues with testing. So let's say you get tested and you get your result in 4 days. Well, the problem with that is that your peak contagiousness, that like when you're spewing out the most virus in whatever setting you're in, is really 2 or 3 days before you got tested and 2 or 3 days after you got tested. So if you get your result in 4 days, you've already missed your 7-day window of spreading the virus to everyone, right? Mm-hmm. So it's like, oh, now I found out I'm positive, now I'm going to quarantine. Well, great job. For the last 7 days, you've already been kind of spreading this thing. So that's the challenge we're having, is that we count that as a test and we maybe even be patting ourselves on the back like, oh, good on us for getting more tests out there. But the testing delays are really so bad that I don't think that they count towards an effective test that would reduce transmission. So that's one thing. The other thing is that sometimes tests don't equal people. And I think this gets missed, right? So Thomas walks in and I say, great, let's actually test you in your nose. Let's do a throat swab and let's draw blood. That's 3 tests on Thomas. I count that as 3 tests. So you see the data and say, oh, wow, we've done 800,000. Maybe you have to divide that by 2 or 3 if you're kind of looking at how many people you've tested. And then when you like compound that with like, well, certain communities are getting tested more than others, and then there are these testing delays, it's no wonder that we're so far behind on testing, because even with all those kind of caveats, even the absolute number, even if you're going to kind of look at this with the rosiest of glasses, it's still far insufficient from where we need to be. So we needed to be at around 1 million tests per day. We're around 800K per day. And that was back in April. And now we're kind of like, we have double the number of cases. And so we're really losing the war on testing. And the reason people don't talk about it is that I think it's just been a losing battle for so long. It's almost kind of boring to talk about the fact that we're still losing.
And why are we losing the war on testing? What's preventing more testing from happening?
So the clearest answer, I think, and it's going to feel like a dodge, but I'll tell you, I've really tried to understand this deeply. And the clearest answer I can come up with is the lack of federal leadership. Because what's happened is that we have supply chains that are broken across the board. You know, everything from, just think about it. If you have to get a test, right? You need a cotton swab in your nose. Where's that cotton swab coming from? Maybe it's coming from North Dakota. Okay, great. So you get swabbed. Then it has to go into some liquid media. Where does that liquid come from? Maybe that comes from Atlanta, Georgia, because the CDC is producing it, and they were for a little while. And then you have to go and get the RT-PCR reagents. Where are they coming from? Maybe they're coming from New Delhi, because that's where we ship in some of that stuff. So it's coming from all over the place, and we've got broken supply chains all over the place. And in the absence of a strong federal sort of mandate to say, hey, let's get a real solid supply chain going and get that out to the hardest hit areas, what we've compounded that with is essentially a free market system where we say, hey, we've got 100 test kits. Which states are interested? And perhaps, New York is hard, is hard hit, or let's say Florida today is hard hit, and Connecticut's got its situation much more under control. So they're sort of like, yeah, we'd like to apply for those test kits. We'd like those. That sounds nice. And Florida doesn't have the money because they're out doing other things with their money, trying to, get COVID under control. So literally states are competing against other states. And who wins is the most heavily financed state, or the state that's kind of under usually the best leadership and management. And that doesn't necessarily correlate with where the need is at. And so these states that are already hard hit, already struggling, typically aren't the ones that are going to get the funding together to go and procure this stuff.
Mm-hmm. Great, thank you. We're gonna try something here and launch a poll. Give it folks on the call. We've got about almost 20 folks participating. Want to try and get a sense of who's in the room here with a few polls, starting with kind of attitudes and behaviors around how folks are managing everyday errands. So I'm gonna, you should have a poll that pops up on your screen here, and you can respond to the poll if you are accessing via video. On average, how often do you leave your home to complete errands such as grocery shopping, banking, etc.? Give folks here just a minute. All right, so it looks like we've got some folks who are outside the house more often, some who are barely leaving the house at all. Can you talk a little bit, Rishi, about the relative safety of kind of these day-to-day or everyday activities like going to the grocery store, picking up takeout, whether waiting for the bus, and how best to protect ourselves in those day-to-day experiences?
Yeah, absolutely. One thing, we're sitting here in Oakland, and there are fires, all around us essentially. And so there's unhealthy air compounding this problem. And that obviously makes life a lot harder. We're all kind of cooped up, and, I'm guessing that we're all feeling a little bit of cabin fever. And so you want to get outside, you want to be able to spend a little bit of time in the park and things like that. And a lot of my comments I'm going to make about going to the grocery store, to answer your question, are very different than going to a park or going to take a hike and things like that. So I don't want people to conflate these things in their heads. So if I'm going to the grocery store, let's say I want to go and pick up, stuff for the week, the things to keep in mind are, you want to be wearing a mask on your walk there. You're going to be passing folks, but that's not your highest risk part of the trip, just to be super clear. A lot of that is, I think, just making sure that you're doing the right thing, and you don't want to be kind of fiddling with your mask and things like that. You get to the grocery store, you walk in, and you generally want to stay away from other people, right? Like, again, just think of them as kind of these little spheres of potential risk. And so you want to make sure you're not congregating in certain areas. If people are like picking tomatoes, then maybe you just wait and get your tomatoes at the end, that kind of thing. A lot of grocery stores have started creating one-ways to help create better flows of traffic. They've, at the Trader Joe's that I go to sometimes, they say, hey, don't just congregate right up front, kind of go to the back, get your other stuff, and get this stuff at the front later. So those are the things you want to keep in mind. In terms of touching surfaces, I personally, I'll just tell you what I do. I basically just touch whatever I need to grab, put it in a bag, and take it home. And then when I come home, wash my hands. And I am usually pretty thoughtful about not rubbing my eyes, not touching my face. Essentially, I'm just going to do it right now for viewing reasons, but there's a T kind of around my eyes, down my nose, and on my face. That is your T zone. So you just don't want to touch your T zone. Essentially, the virus doesn't get in through your elbow. It doesn't get in through your ear. It doesn't get in through your knee. It gets in through your T zone. And so if you can protect your T zone, you're good. And so essentially, go on these trips, wear a mask, recognize that you actually might have COVID yourself, but may not know it. And if you kind of behave that way, it makes you much more thoughtful. And come home, wash your hands, and call it a day. I typically will take stuff out of the bags or whatever it is and put it in the fridge, and I usually trash all that other stuff. So I don't keep that stuff around the paper bags and things like that. I personally, just being totally honest, I don't spray down the bag or anything like that. But I will tell you, if my parents were here, and my parents are, as you might guess, older than me, they are much higher risk. And so I would probably do things slightly differently. If they were here, I probably wouldn't have them go get groceries. I would get all the groceries for them. I probably wouldn't want them, handling the groceries after I came home. I'd probably take care of that. So those are things that I would do if I was living with someone that was higher risk than myself. But that's my day-to-day.
Mm-hmm. Can you talk a little bit about gloves? I think there's this idea like, I wear a mask. If I'm wearing gloves, that provides some protection. Gloves, no gloves, or when should you wear gloves?
So viruses have been around for a long time. They're pretty good at getting into nooks and crannies. So one nook and cranny on your hands is your fingernails. And so one thing that you may have noticed in the hospital, most people are encouraged not to have artificial nails, to clip their nails, things like that. And I do the same for my kids. I don't want them kind of to have long nails and get stuff underneath them. Gloves offer a smooth, let's say latex gloves, a smooth surface that viruses typically aren't great at adhering to. So if I was to say, like, is there a reduced risk? There's no question. Yeah, there's almost no question. Latex gloves are going to have a reduced risk compared to skin. And having said that, do I personally wear gloves? I don't. You could do that, and it would be a very reasonable thing to do. But I personally don't do it for no real good scientific reason, probably out of laziness.
All right, thank you. Before we switch to another topic, as you're out and about in the community, what do you see the businesses are doing well when it comes to protecting the health and safety of their customers, and what kind of gives you pause, or what do you think businesses, and as I think about our work in the DIA and our work with businesses in the community, what could businesses be doing better to protect their customers?
So one thing that I think is kind of interesting is that we're all having a much more reduced ability of having kind of face-to-face interaction. And one thing that businesses do is they model behavior, right? So I might see 5, 6 people on my one trip to the grocery store. The grocery store clerk sees hundreds of people. I mean, hundreds, right? They're at risk. They're at much, much higher risk than I'm at. And this is true of most essential workers and businesses that are open. Many of them are essential workers. You know, if you're at the post office, you're an essential worker. If you're at the grocery store, or if you're at the pharmacy, you're an essential worker. So these groups are at much higher risk. Like, let's just start with that. And so I think a nice thing to do for all of us is to start by saying thank you to those folks because they're out there every day and putting themselves at risk to kind of keep our entire economy kind of chugging along. Even though it feels like it's a bit janky right now, it is chugging along. And so that's the first thing I would say, is that human interaction is important. Saying thank you and maintaining these social bonds is critical. I think a lot of people are starting to get depressed and anxious because there's not a lot of that sort of social context. And so for those brief moments that you get it, please, take advantage of that. The things that I think people are doing right are modeling good behavior. And most people I see in these settings are wearing a mask themselves, are being thoughtful about, how they deliver food to, let's say, someone if they're doing takeout, or, kind of being really mindful of that. Because if they didn't do that, that would send a lot of kind of mixed messages like, oh, this person's not doing it. They're at high risk. They seem fine. Why am I doing it? So I think modeling good behavior is definitely a big thing that they're doing right. In terms of things that folks are doing wrong, it really depends on the business. Like if your business is that you're a bar, or if your business is that you're a club and you're opening, that's really not great, because you're inviting people into your walls, and you're setting people up. And people, I think, falsely believe that if the owner of a bar is opening, or a club is opening, then it must be safe. Someone must have thought this through. And in fact, the answer is no. Maybe no one's thought it through. And in fact, I can tell you no one's thought it through because they're opening up. And so that sort of signaling is definitely wrong. And I'm not suggesting it's happening necessarily in the Dimond, but I know clearly nationally it's happening. And so that's one example.
Great. I want to shift gears here. I'm going to open another poll and want to talk a little bit about schooling. It's back to school time. Rishi, you have a 3-year-old. Thomas, you have a little one too. Some folks on the phone probably do. So I'd love to get a sense from people on the meeting. If you had school-age children right now, you may or may not, but if you did, would you feel comfortable sending them back to school for in-person instruction right now? Give folks a minute. All right. Well, we have a clear, I don't know that I've ever seen 100% of any size group agree on anything, but clearly strong feelings about not sending kids back to school right now. Rishi, what about you? You have a 3-year-old. Would you send your kid to school for in-person instruction right now, and why or why not?
Yeah, so first of all, it's awesome that 12 people are agreeing. I feel like in this
right.
political climate, it's hard to get 12 people to agree on anything, especially 12 is an interesting number given the legal system that we have. So probably a lot of things could be decided with this group of 12.
That's
right. I think it's a really complicated question, and I'll share kind of what I think are valid points on both sides. So I think with school-aged children, let's just define that a little bit more. I would say less than 10 is school-aged, and over 10, I think, is a different ball of wax. Okay. So under 10, there is some data. So the American Academy of Pediatrics put out a paper on this, and they said, hey, we've looked at index cases, the first case in a household. How often is that a child? And it looks, it's usually less than 10% of the time. So the index case of COVID in a household, when that is less than 10% of the time, is that a child under the age of 10. So that was one data point. And you can take that for what you will, especially in the context of COVID-19, where there weren't that many kids going to school in the first place. You can say, well, how often does that even happen? So it's not like you can just kind of accept that as absolute truth, but that was one interesting point. We also have other countries, and in studies in other countries that have opened up kind of much more than we have at this point, specifically Europe, Japan, New Zealand, it seems like kids in those settings, young kids, are not major contributors to spread of COVID-19.
Mm.
So that's one kind of set of arguments. On the other side, you've got the other set of arguments, which is it may be true that kids don't spread it as much. It may be true that they don't get sick as much, but there is a risk of severe disease. You know, we know that there's something called MIS-C, if you want to look it up. It's a long, essentially, set of words, but inflammatory is the I. And MIS-C is essentially this thing that kids get. They get rashes, they can get heart problems from COVID-19, they can get serious disease. And these are young kids too. There have been kids that have died from COVID-19. There have been young adults that have died. And then there are other key stakeholders, right? There's parents and grandparents and multi-generational families. We talked about that before. We've got teachers, principals, staff at the schools to be thoughtful about. Many of those folks are also high risk. And so there are lots of key stakeholders beyond little kids to be mindful of. And so I totally understand that side of the fence as well and say like, hey, that doesn't make sense. Now, going back to the first side, just playing, back and forth a little bit like a tennis match. Then they say, well, essentially when you have young kids, a lot of their neurocognitive development is occurring in the first 5 years, or let's say first 10 years, but really in the first 5 years, you see a lot of that happening. And so they really need stimulation around other kids. They don't need to be in front of a screen. And in fact, there are strict guidelines on how many hours of screen time a child should get. And it's not 8 hours a day. And so, so the idea of distance education, if that means a screen, is really flying in the face of what we know with neurocognitive development for young kids. Then there's issues of low income status. A lot of these kids may only get a solid meal when they're in school. A lot of kids might have a domestic situation that's violent and they only get screened or caught when they're at school. So there are other kind of side issues there as well. It goes back and forth. And then there's, of course, the situation of essential workers. If you're an essential worker and you have to work because you're, let's say, an emergency room physician or something like that, you can't bring a child with you and society wants you to keep working. So you have to have your child go. So for me, I'm considered an essential worker and I have sent my child to daycare under that status. And I definitely recognize that there's a real risk there, not just to my child and to our family, but to the greater community. If my child is now transmitting it to another child, so on and so forth. So it is a definite concern. It's a worry. And I think one of the things that I would walk away with this discussion saying is that all things have a risk and we have to take calculated risks. And as a society, that decision should probably be left up to the teachers and the schools. And we can't force this down people's throats. And what's right for Miami is not right for, let's say, Dimond, because of the local circulating levels of disease. So all these things matter, and how people are actually gowning, or not gowning, but gloving up, or, if they're in a certain cleaning environment, how they're, wearing face masks and things like that. So all of that plays into it, but I didn't want to kind of just go through that list. I want to kind of explain my thought process.
Yeah, great. Going to do one more poll. We've got about 15 minutes left. We've got a lot of questions still. So I want to do one more poll. I know I'd love to talk just a little bit kind of about socializing, social circles, and specifically kind of socializing outside of maybe our immediate household. I know many of us are probably feeling a little bit stir crazy by now, if not a long time ago. And I'm tired of wearing masks every time I talk to my neighbors. So would love to get a sense from folks who are on this call, which of the following best describes your current level of safety when interacting with people outside of your household? So people with whom you don't live. So do you not interact with anyone else? You do, but you're always safe. You're pretty safe. Don't worry, this is anonymous, by the way. This is anonymous. There won't be any like COVID shaming or anything here. Generally safe, but maybe less cautious, let your guard down with some folks. Or, you're just kind of over it. You regularly spend time with friends and family without kind of masks or other precautions. All right. Well, it looks like folks are generally practicing kind of safe socializing, generally wearing masks, generally practicing distancing, maybe a little bit less so with a small group of people with their pod, so to speak. Can you share, are there conditions under which we can let our guard down a little more? And what are the limitations on that?
Yeah, it's a great question. And I mean, I think this gets down to balancing reality with, two different realities, like the reality of like our needs as human beings, and we're social creatures and really always have been, with the reality of knowing that this transmits person to person and it's a pretty severe disease. And, with what I said earlier, I'll just kind of dovetail this now. My family has taken a calculated risk, which is we're going to send our son to be part of daycare, and that's essentially the only risk we take. So on that list, I'm always trying to answer these questions for myself.
Mm-hmm.
We'd be in that first group. We don't socialize with anyone outside of like this group. Essentially, I do everything on Zoom. I don't socialize with anybody. I haven't seen my parents, in months. And so months and months. And so that's a calculated risk. And each of us has taken risks, and you define a pod, and I suggest people stay within their pod. And that is to say, like, whatever you define that pod as, maybe it's, your close family and friends, maybe it's your neighbor, like however that's defined, that's how you keep it. And you trust everyone else in the pod defines it the same way, because it's when different people are kind of treating pods differently that this spreads, right? Like if I believe that my pod is Ryan and Thomas, then I find out tomorrow that Thomas actually enjoys going to concerts every weekend. And I'm like, oh, I'm not even getting to go to concerts, and yet I'm getting all the risk of having gone to a concert. So that's how you have to kind of trust within your pod that everyone's behaving in the same way.
Great. Love to wrap up with a little bit of a look towards the future. There have been a lot of questions, both in advance of this meeting, but also in the Q&A here around how close are we to having a vaccine? It seems like we won't be back to normal or some new version of normal until we have a vaccine, and there is, as you shared, kind of a level of use or adoption. How close are we? What do you think?
So generally speaking, once a vaccine is out there, it gets delivered to the people that are the highest risk first. And in our current climate, that would be healthcare workers. So healthcare workers are usually considered first priority for getting a vaccine. And in many settings, we might see that it'll be required that if you want to be a healthcare worker, you have to get a vaccine or have to prove immunity to COVID-19. So that's going to be the first group. And then people are going to watch carefully, probably, to see how they do. Are there any sort of untoward effects? We're going from thousands to tens of thousands, maybe hundreds of thousands at that point, right? So we're going to see, are there any sort of new anomalous issues related to the vaccine? And then maybe a few months later, and I'm just kind of guessing here a little bit, obviously, everyone's guessing, but then you're going to say, okay, now let's roll out the second wave. Maybe the second wave is the next group of folks, and that might be senior citizens living in institutionalized settings. So maybe skilled nursing facilities or other places where we're seeing a lot of bad outbreaks, because the benefit risk is thought to be such that the benefit outweighs the risk. The reason that might be second is because, again, remember, the vaccine is tried out on 18 to 65-year-old individuals. That better reflects the healthcare worker community than it does the skilled nursing facility community. So that's why that would probably be a second wave. And then maybe after that, it'd be rolled out to the general population. So there might be kind of waves that we see. And so that's the first thing. So saying that a vaccine cleared phase 3 doesn't mean I can run out to, wherever, Walmart or wherever, and just get vaccinated. It might be months later. Then there's logistical issues. I mean, we've been dealing and talking about testing for how many months and haven't figured it out? If that's any sort of a prequel to the drama that will unfold once the vaccine is out, I think that it stands to reason that it'll also take months for that reason as well, right? So even having a vaccine. And then you're going to have the debates. Like we've had mask debates that have been furious, and the vaccine debates, I believe, are going to be even more furious, because there you have what I would call a much more legitimate concern about safety, because again, it's not been tested in everybody in every age cohort and setting. And so there are going to be people that legitimately are like, don't get that near me. And other people say, hey, don't come near me if you're not vaccinated. And so I think we're going to see a lot of that sort of play out. So as to when all of this is going to happen, at the beginning of this, we said, hey, maybe 12 to 18 months. That brings us to Q1, Q2 of next year. I still believe that that is probably an accurate sense of the timeline. I have no reason right now in August to think that that's inaccurate, or maybe it'll be delayed, or maybe earlier. I would, if I was betting, I would bet on Q1 or Q2.
When we start seeing a vaccine, and we see a vaccine available for the general population.
Yeah, and I don't expect that anybody unless I'm not clear on who's on this call, anyone on this call is likely to be able to get vaccine in calendar year 2020.
Can you talk a little bit in terms of a follow-up question on vaccine development? What is happening to shorten that development timeline, other than removing, like you mentioned, in many cases, removing the phase 2? Or is that really it? That's really what's shortening the development timeline?
Yeah, I mean, so phase 1, phase 2, phase 3, that implies that there are 3 checkpoints, right? And that's it. The honest truth is that each vaccine costs millions and millions of dollars. And so they have lots of internal checkpoints. So let's say there are 30 or 40 or 50 regulatory checkpoints. The reason for that many checkpoints, where you stop, check the data, stop, check the data, the reason for those processes is that no company wants to invest if they're not going to get a market at the end of it, right? What the government has essentially done is they've de-risked this. They've said, hey, let's just assume that this works and go ahead and we'll foot the bill. We're going to go ahead and guarantee that if this works, even on kind of in a low way, let's say a VE of 50% or 55%, like in some capacity, if it's working, we will guarantee that we'll distribute this and give you deals to distribute this nationally and internationally. And so that's done is a lot of these regulatory checkpoints, the companies have said, great, you're going to de-risk it. Instead of having 40 checkpoints, we're going to only have 12, because we know at the end of the day, there's a great market here. We've got countries lining up to pay for this thing. So that's one thing. The other thing is parallel play. So generally speaking, again, when you're in a risk environment, you do things in series. You say, okay, let's do this. If it works, then we commit to this, then we commit to that. In this environment where it's all fairly de-risked, they say, you know what, let's just start getting everything together to churn out lots and lots of doses. Let's get the logistics up and running to assume that we're going to have a really successful drug here and get the factories prepped and ready, which is great. I think that part makes sense. What I'm worried about is that even though on paper that sounds good, in reality, because of the lack of federal leadership that I've seen with testing, it'll play out again with vaccines.
And which vaccines are showing the most promise right now? And is it likely that there'll be multiple vaccines available in that kind of Q1, Q2 time horizon?
Right. So they all go by essentially very technical names, but the companies that you might have heard of, or the players that are kind of involved, there's AstraZeneca, Oxford, Moderna, and there's a bunch of these. And they're all basically doing similar things, but they may be kind of attacking the problem from a different angle. So there's a protein on the surface of the virus called spike protein. They're all trying to attack that spike protein somehow. So this vaccine says, hey, let's trick the cells into using this RNA and it makes spike protein. Another vaccine says, let's trick the cells by using this DNA and that makes spike protein. So they're kind of very similar enough strategies. But of course, it's a game of inches, and it's the kind of race where coming up third or fourth may not mean a lot. And so you really want to be the first, second, or third player out of the gate, especially because, I would assume that there's going to be some fragmentation of the market where they say, hey, what's your capacity for creating vaccine? Okay, you can hit this market versus that market. So there's going to be some of that, I would assume, especially internationally, where some countries are in agreements already with other countries to say, hey, let's create kind of a bit of a co-op, and together we're going to procure this many vaccines and we'll have a deal kind of worked out. So there's going to be some fragmentation of the market, high income countries versus low income countries. A lot of that stuff will likely happen. And I don't have a horse that I would say, hey, watch this one versus that one. A lot of it's going to come down to when the phase 3 trial finishes. I think a lot of times people are like, oh, this one came out of phase 1 and 2. It's the early one. Not really. I mean, when you're talking about logistics around dozens of people or 100 people, it's quite different than getting logistics around thousands of people. And really, that's what's going to be telling. There's also a lot of splashy headlines. I think in the last few weeks, there's been a very interesting headline coming out of Russia, a Russian vaccine that's been out. And, the challenge there is, and I think Dr. Fauci said this really well. He said, if we wanted today, if we wanted to just release a vaccine, we could do it. We have about 15 of them. That could all just be released. The problem is that they haven't been tested for safety and efficacy. And that's true of really any sort of vaccine out there. Yeah, you can say you have a vaccine and that's great, but nobody's gonna open up their arm and get your vaccine if you can't prove in a way that feels transparent that it's safe. And that's going to require a peer-reviewed journal where other scientific researchers that are not funded by that organization or that government entity come in and say, hey, this is legit, and that we trust that the data is legit, right? That we actually trust the entities to be putting out legit data in the first place, that then you can review and take at face value. And so all these things are going to create a lot of scrutiny and a lot of geopolitical infighting, because obviously there's a lot of money at stake. Some countries don't want to be reliant on other countries for a vaccine, and they'll say, we'd rather wait 2 months and have our own vaccine rather than find out that you've been sending us faulty doses and things like that. So I think that there's going to be a lot of sort of again, geopolitical fighting that goes on around this, and a lot of delays, because some countries are going to say, I'd rather just wait to have our own vaccine because that way I'm not reliant.
Well, we're coming up on 8:30. I know you have a 3-year-old who is probably ready for you to tuck him in. So I want to thank you so much for being here tonight and for giving of yourself and your time and your expertise to this community and to our participants. I also want to thank all of this is where I would pause right now to let everyone clap. If we were, all in person. So hopefully everyone's clapping at home. Thank you so much. It's been great to have you.
Thank you so much, Ryan. I really appreciate it. And Thomas, for doing all the technical work. I appreciate you both.
Yeah, thank you.
Thank you, Rishi. Thanks everybody else for joining.
Yeah, thank you. And thanks everyone for being here. Hopefully we got to most of the questions. Really appreciate your support. If you are interested in the DIA or in learning more about the DIA or in becoming a member and supporting more great programming like this, you can do that at our website, dimondnews.org. Also want to just put a plug in that we have a community survey open right now. If you're interested in helping to shape the future of the neighborhood, then please complete the survey that's linked here. It's available at bit.ly/DIA survey 20. Just a few questions on the future of the neighborhood. And thanks everyone for being here. Really appreciate your time.